And I would now like to call Dr. Randy Weber to the podium to introduce our Christoper O'Brien lecturer. Thank you.
Good morning, everyone, and thank you, Carol. Before I introduce Dr. Thompson, it's my pleasure, if I could have those slides up, please. This morning, as chair of the foundation, it's my honor and pleasure to introduce our traveling scholar this year. And this is in honor of Professor Chris O'Brien. Chris was a leader in this society and had many friends around the world. As he became ill, and about 5 years ago, we knew that Chris was not going to be able to surmount his disease and survive. Many of us got together and did really two things to honor him. The first is a Traveling Scholar Award. As you know, Chris was an internationally renowned educator. He was a Hayes Martin lecturer. He was a council member in our society, but he was really committed to training his fellows and residents, not only in Australia, but sending many of his trainees abroad for outstanding fellowships who have now gone on to leadership positions. He's dearly missed by many of us. His family is pictured here, and unfortunately his elder son, Adam, tragically succumbed about a year after Chris's death. He has a lengthy bio in your program, and I would ask that you read that and remember many of Chris's contributions. Our past recipients for the Traveling Scholar Award have been Karsten Palm from Sydney and also Eric Moore from Rochester, Minnesota. This comes with a $10,000 award, and they used those travel funds to visit institutions in both of our countries. There's a strong tie between our two societies, and this traveling scholar permits cross-fertilization both in North America and in Australia. So this year, I'm pleased to introduce to you Dr. Porsidou. He's Associate Professor of Radiation Oncology at Queensland School of Medicine. I'm not going to go through all of his bio because we're running late, but I will mention a couple of things. He's published some outstanding work on the role of imaging and deciding upon which patients should have neck dissection following non-surgical therapy for head and neck cancer. He was taught and mentored by Lester Peters and June Corey at Peter Mac, so he came with a great foundation and credentials to a leadership position in Queensland. During his visit in North America, he will be at Princess Margaret. He will visit Lou Harrison at Beth Israel and also visit David Brazell, and he'll be asked to give presentations at each of those institutions. So I can't think of a better person for our traveling scholar this year, and I'd ask Sandro to come up and receive his award. Could I have the next slides, please? Could I have the next introductory slides, please? So at this time, it's my pleasure to introduce to you Dr. John Thompson as our Christoper O'Brien International Lecturer for this year. Our previous lecturer, and this is given every 4 years at the international meeting, was Donald Morton, who was also a leader in the treatment of melanoma. You'll note that Dr. Thompson is director of the Melanoma Institute in Australia, one of the world's largest melanoma centers. He's published over 500 peer-reviewed publications related to melanoma and is definitely a thought leader in the field. Chris, as you know, published extensively on both non-melanoma and melanoma skin cancer and helped develop a new staging system for non-melanoma skin cancer. And so these lectures are meant to educate us and heighten our awareness of both melanoma and non-melanoma skin cancer And remember, in North America, it's estimated that 1 in 90 Caucasians in this century will develop melanoma skin cancer, which of course has a higher lethality than non-melanoma skin cancer. And it's an area of exciting research today as we have developed targeted therapies to combat this lethal disease. So it's my pleasure to have Dr. Thompson come and address us with the Chris O'Brien Lecture. Dr. Thompson.
Well, thank you, Dr. Weber. Dr. Bradford, ladies and gentlemen, it's an enormous honor to be here amongst you this morning to follow in the footsteps of Donald Morton, who I'll be mentioning in the course of this presentation, and to give the Chris O'Brien Lecture. You've heard a little about Chris O'Brien. Must be a sign of age, but he was my resident many years ago, and we worked together very closely in the Sydney Melanoma Unit, and many of the publications that he produced on head and neck melanoma were joint publications. This was Chris as we knew him in the operating room. This is how you probably knew him, giving lectures to the Head and Neck Society and other august bodies around the world over many years. Very briefly, he was born in Sydney in 1952, graduated in 76, and he completed his residency and his general surgical training at the Royal Prince Alfred Hospital, the hospital associated with the University of Sydney, and then fellowships in London at the Royal Marsden Hospital and in the University of Alabama. He then came back to Australia in 1987 and became a consultant head and neck surgeon. This was Chris then. You probably get an inkling of what Chris was like just from this picture. That was Chris. He became head of the head and neck department at the Royal Prince Alfred Hospital and expanded the unit very, very rapidly. He worked closely in those early years with the Sydney Melanoma Unit, and inspired, I think, by the Sydney Melanoma Unit database, he decided that he should establish a head and neck database, which is now the largest in Australia and has over 8,000 patients on it. In 2002, he founded a head and neck cancer institute in Sydney and established a basic science research program, international clinical fellowship program, and that's how it all began. He then moved on to an administrative position as director of the Sydney Cancer Centre, based at the Royal Prince Alfred Hospital, but kept his clinical and his teaching and research activities going. And he was often invited internationally and nationally to be a visiting professor. And he gave several named lectures of which he was very proud, including the Hayes-Martin lecture, the Eugene Myers lecture, the first of the Jatin Shah lectures, and the Semin lecture in London. He founded the Australian New Zealand Head and Neck Society, of which you've just heard, and he was its president in 2004. He was invited to join the Council of the American Head and Neck Society in 2005. And as we've just heard, he was subsequently honoured by having both a lecture and a travelling fellowship named in his honour. He also became a media personality, and he featured regularly in what was Australia's first and undoubtedly most successful medical reality show, RPA. The television team simply followed hospital doctors around and filmed what happened. He developed a proposal for a large comprehensive cancer centre to be built on the campus of the Royal Prince Alfred Hospital, and he received a personal commitment from the Prime Minister of the day, Kevin Rudd, who committed federal government funding. And this building is now well advanced. It's now to be called the Chris O'Brien Lifehouse at RPA. It'll open its doors in the middle of next year. This was how the Australian media knew Chris. Here he is with the Governor of New South Wales, making sure that things are running smoothly for his fundraising campaign. Here he is with one of the leading television personalities in Australia. He knew how to work a room. Here he is with the Lord Mayor of Sydney, making sure that that side of things was right, all the planning approvals were to be granted. Here he is asking Prince Charles if there might be a lazy £1 million or two in the Duchy of Cornwall. He wasn't successful in that. This is the Lifehouse, which is rising from the ground as we speak. But that was all the good stuff. The bad stuff happened in 2006 when Chris was diagnosed with a brain tumour, but he refused to give up. He devoted himself tirelessly to his dream of establishing at the Royal Prince Alfred Hospital a world-class cancer centre. And he also wrote that book that you've just seen the picture of. The strain of the disease is already telling in that picture. So that was Chris O'Brien, and this is his lecture. I'd like to talk briefly, because time is short, about the subject of lymphatic drainage from cutaneous malignancies of the head and neck, because I think we now have a lot more information than we used to have, and I think these have important implications for management. All this work has happened in Sydney. This is a picture of Sydney. It's important for three reasons. One, it shows you what a nice place Sydney is, but Toronto's nice too. I quickly add that. I talked to one of the locals, though. They said, "Say, you ought to come in winter." If you're not convinced that the world is round, that's the second point of this slide. It really is. But the most important bit is that the sun shines most of the time, and that's why we've got such a skin cancer problem in our country, particularly when it's filled with people with names like O'Brien. We have a huge Celtic population. About 70% of the Australian population have at least one Celtic ancestor, and this is why we have the huge incidence of melanoma that you see here. Queensland has by far the highest rate of any country in the world, a little lower in New South Wales and lower again in Victoria. The incidence, for reasons we don't fully understand, continues to rise year by year, more so in males than in females, despite every effort to reduce sun exposure from earliest childhood. It's now about 10% of all cancers in males, about 10% of all cancers in females, and it's by far the most common cancer in both males and females who are young. Putting it another way, the lifetime risk, and these figures are now 4 or 5 years out of date, they take a while to catch up, lifetime risk of 1 in 24 for males and 1 in 35 for females. So it's an epidemic. I work at the Melanoma Institute Australia, a purpose-built $50 million building in North Sydney, and looking after patients with melanoma is all we do. Well, I also do some other surgical oncology. The number of patients each year just continues to rise. We're now seeing about 1,600 new melanomas a year. So what about lymphatics? This slightly fuzzy picture, because it was taken through glass, is actually a picture of the original atlas by Sappi in the mid-1850s. And for Sappi, it was all very straightforward. He did this mapping and found that lymphatics were very predictable. They never crossed the midline. If they were above the waist, they always went to the axilla. If they were below the waist, they always went to the groin. And this led to the concept of Sappi's lines that you see here, so that there was a strip down the middle and around the waist, about 5 centimetres wide, where there was some ambiguity, but the rest of it was absolutely straightforward. We now know from experience with lymphatic mapping for sentinel node biopsy, which was first described by your previous Chris O'Brien lecturer 4 years ago, Donald Morton, that Sappi got it wrong, and that very often lymphatics do not travel in the way we expect them to travel. Morton's concept was simple. You injected blue dye and followed it, and it would end up in a lymph node, the so-called sentinel node, before onward passage to other nodes. And it worked. It was a very simple procedure. Initially, we just did it with blue dye. Subsequently, we used radio-labeled tracers. And if you look at this picture, you can see an afferent lymphatic going to the lower end of a sentinel node in the groin. This happens to be. But if you look carefully, you can also see a lymphatic bypassing that node and actually going to another sentinel node higher up, which emphasizes the importance of doing the test carefully, or you'll get the wrong answer. The pathologist, of course, loved the technique, because instead of getting a huge mass of blubber from a radical axillary dissection or groin dissection or neck dissection, they got a node, and they could examine it very carefully. They could do immunohistochemistry, and they could pick up very small volumes of material in the node sometimes just a few cells, but they could very accurately find these in the sentinel node. It is now established as the most accurate staging test we have available for patients with primary cutaneous melanoma. It's also, I think, becoming increasingly clear that for high-risk squamous carcinoma and Merkel cell carcinoma probably as well, it's a very useful and accurate staging test. For melanoma, there is now compelling evidence from the first multi-center selective lymphadenectomy trial that Donald Morton set up, and also from some large non-randomized studies, that patients who are sentinel node positive have a greatly improved survival outcome if they have an immediate complete lymph node dissection. And in the course of all this lymphatic mapping that's been done for sentinel node biopsy, we have gained these new insights that I'm talking about into lymphatic anatomy, and many of them have quite important implications if we're going to treat our patients rationally, whether in the head or neck or elsewhere. In terms of prognosis, this is just our first 1,000 or so patients treated in Sydney. Huge difference if you're sentinel node negative or sentinel node positive in your disease-free survival or your melanoma-specific survival. Very useful for the patient and for their treating physician. And these are the curves. This is one of Donald Morton's slides from the third interim analysis of MSLT1, which show that if you are sentinel node positive and have an immediate node dissection, your 5-year survival is very dramatically better at 71% than it is if you have no sentinel node biopsy and a dissection when disease becomes clinically apparent, 53% 5-year survival. Now, we are fortunate in Australia. We have small particle colloid, antimony sulfide colloid, which gives us very nice lymphoscintigrams. As you see here, an injection site distally, moving up a thigh, 2 channels which converge on a single sentinel node. Another patient with 2 channels that go very clearly to 2 sentinel nodes in the groin. Sometimes there's a dominant channel going to a very obvious sentinel node and a much fainter channel going to a much less prominent sentinel node. It's really important to get both nodes out and examine them. In this particular patient, the node with the arrow on it was actually the one that had the metastatic disease in it. So unless you do it carefully, unless you have the right agent, you may get the wrong answer and do the patient a disservice. Certainly this lymphatic mapping was useful for central abdominal or central back lesions. Here's one right next to the umbilicus that goes to both axillae and both groins. We discovered interesting things, that things were not as Sappi had always suggested. Here you can see 2 lymphatic channels coming up from a primary melanoma on the forearm. One goes, as expected, up to a sentinel node in the axilla, but the other goes up with the cephalic vein directly to a node in the supraclavicular fossa. And this is not a skip metastasis. This is direct spread in a lymphatic to a sentinel node above the clavicle. I thought it was appropriate to put this picture in this particular week, because at the time of the Sydney Olympics, 12 years ago now, this strange blue line appeared around the streets of Sydney. And it seemed that following this blue line, which was in fact the Olympic marathon line, was very much like following blue lymphatics. Usually it travelled in the expected path, but sometimes it deviated from the expected path. Shortly after the Olympics, they had to scrub these blue lines off because some drivers were actually following the blue lines and not the white lines, and it caused some difficulty. In the head and neck, it was a bit the same. Here's a man with a melanoma on his scalp, and his single sentinel node is right down there in the supraclavicular fossa, not what you would have expected. Here's one in the supraclavicular fossa that drains directly to the axilla, a very common pattern, in fact. And most of the ones in the shoulder region and lower medial neck actually drain to the axilla. And there is the blue stained node in the axilla. Very early in the piece, we discovered that you could not predict where head and neck lymphatics were going to end up. This was a young man with a nasty thick melanoma over the angle of his left mandible who drained to a submandibular sentinel node marked with an arrow, but also to one on the opposite side of the neck, low down, and this one in the opposite neck was in fact positive. That was 18 years ago now. He had a right neck dissection and he's fine. Here's another one that drained from up in front of the ear to a submental lymph node, as well as one in level 2. Sometimes they go the other way. Here's a melanoma overlying the manubrium that drains directly up to a submental lymph node, and that was the only sentinel node in this patient. Quite extraordinary. At one stage we got interested in ones in the collar region and actually mapped the sentinel node sites that drain from the right collar region marked here, and it went to all these places. It went to the ipsilateral neck, to the occipital region, to level 5 and level 2, believe it or not, on the opposite side of the neck, to the right triangular intermuscular space, to the right axilla, and even across to the left axilla. So head and neck surgeons beware. I almost shudder with embarrassment when I put this particular slide up. It was one of Chris O'Brien's early melanoma publications, and it was when we were trying to make sense of the first batch of head and neck lymphoscintigrams that we had in the early 1990s, as we were beginning to get used to the concept of sentinel node mapping. And as was and perhaps still is the custom with head and neck surgery, Chris wanted an algorithm. He wanted something that would unify everything, and this is what he came up with. Does it remind you of anything? Maybe it's a little bit like SAPI, and maybe it's a bit simplistic. I think we now know that it was much too simplistic. I went to an excellent session on non-melanoma skin cancer yesterday afternoon, but I have to say, and I may be frog-marched off the podium for saying this, that I was a little disappointed that lymphatic mapping wasn't even mentioned and people kept talking about algorithms. I think, this is the 21st century, and I think we have to somehow try and define lymphatic drainage patterns in individual patients if we are able to, and it's pretty simple these days. It will define very clearly the lymphatic drainage from the primary tumour site, and then you can be much more rational about your treatment planning, even if that doesn't involve sentinel node biopsy, and I'll show you why. We recently looked at lymphatic drainage from melanomas on the forehead, and we managed to find 152 such patients. We had the concept that maybe from the vascular supply of the different areas of the forehead, we could predict where the lymphatic drainage might be. This proved not to be the case, and what we found was that the lymphatic drainage went every which way. Preauricular parotid nodes in more than 80% of the patients with forehead melanomas. Some, however, went to level 1, a good proportion to level 2, some to level 3, some to level 4, some to level 5, and other were the postauricular and occipital nodes from the forehead. Even more surprising is the fact that a proportion of these patients, in the grey you can see, drain to contralateral nodes, from one side of the forehead to nodes on the other side of the neck. So without defining the drainage in an individual patient, you really have no idea how to treat them. Here's one, melanoma on the left forehead, draining to a level 2 node on the left side, but also to a node right down in level 5 of the right neck. This is the lateral view of that same patient, showing it coming down in front of the ear, across under the jaw, into the other side of the neck. Another little study we did recently was to look at patients with melanoma of the eyelid. And we were surprised again to note that 2 out of 13 patients with lower eyelid melanomas actually drained to sentinel nodes on both sides of the neck. In other words, they went from one eyelid across to the other side. In almost all the patients, there was lymphatic drainage to more than one cervical node level, but not universally was there drainage to a parotid node. Only 11 out of 14 from the lower eyelid drained to a parotid node. Again, the conclusion is that lymphatic mapping allows individual patients to be assessed properly, and you can't really base your surgical treatment on algorithms. We also looked recently at the lymphatics draining from the ear. Now, far be it from me in a head and neck meeting to discuss the embryology of the ear, but I'm told that it arises from 6 embryological hillocks, and we thought we might be able to correlate that with lymphatic drainage patterns. A busy slide, but the summary of it is that we couldn't make any sense of it at all. There was no predictability, and often melanomas on the front of the ear drain to lymph nodes behind the ear, ones on the back of the ear drain to extraordinary sites, some to level 1, totally unpredictable and only able to be defined by lymphatic mapping in the individual patient. Perhaps particularly useful as well for Merkel cell carcinoma, which we seem to be seeing more often, and talking to Tim Johnson, who's here today, it seems it's happening in North America as well. There is accumulating evidence, I think, that sentinel node biopsy might be useful in patients with Merkel cell carcinoma. Whether or not that's done, it certainly allows rational planning of surgery and/or radiotherapy. And one of the useful things that it can do is sometimes avoid the need for parotidectomy. Here is one such patient with a melanoma right in the middle of his forehead, and that had been excised, and our radiotherapist was wishing to give radiotherapy to the intervening pathway between there and the draining lymph nodes, and was all worried about giving radiation to the parotid because of the morbidity. We were able to show very clearly that there was no drainage at all to the parotid region. It went straight down the side of the nose across to cervical nodes, bypassing the parotid completely, so that patient was spared parotid radiotherapy. Here's another one that drained bilaterally down beside the nose and across the neck, again with no parotid involvement at all. To try and make some sense of all this, we shared our data with a lady called Hayley Reynolds in New Zealand, who was a biomechanical engineer. And she was able to plot the primary sites and the sentinel node locations on a 3-dimensional model and produce heat maps. And this has all been published. The head and neck part of it was done separately and was published in Head and Neck in 2009. These are the beautiful heat maps she was able to produce, and what they tell us is that the drainage to any particular node field comes from a very wide area. This, for example, is the left axilla, and if you look carefully, you can see that you can drain to the left axilla from as far away as the right buttock, which is something we hadn't expected. This is drainage to the left groin, again, from a fairly wide area, right across on the other side of the opposite buttock. And you can identify little body sites and predict, using this model, what the likelihood is of drainage to any particular node field. So this particular one, body site 21, just beside the umbilicus, there's a 71% chance it will drain to the right axilla, 52% chance it will drain to the left axilla, 66% chance to the right groin, 23% chance to the left groin, and so on. You can do that for any one of these body sites using this particular computer program. About 200 patients with head and neck melanomas were mapped in this way. Those were the primary sites. And using the same technology with the heat maps, Hayley was able to show that to level 2 cervical nodes, there's a wide distribution. Look at that one on the top left there, with areas right down the front of the chest sometimes draining to level 2 cervical nodes. On the right side, a similar sort of pattern with an extension right down to the chest with drainage up to level 2 cervical nodes. These are ones draining to parotid nodes. Notice that the upper eyelid almost 100% of the time drains to the parotid region, but the lower eyelid is shown yellow there and is only in the sort of 60 to 80% range. All very useful information. Here we have the likelihood that a primary melanoma will drain to sentinel nodes in the anterior part of the head and neck. And notice that some on the back of the scalp drain anteriorly. And then the bottom panel, they're ones that drain to the posterior nodes in the neck, the occipital and postauricular nodes. And again, some of the ones in the front of the face drain to those posterior nodes. And this is the figure that tells you that lymphatic drainage can be to sentinel nodes in multiple node fields, and that's from almost anywhere in the head and neck. As for the general body, you can pick a particular body site and predict how likely it is that a node field will be involved. For this particular site 18, just lateral to the eye, 94% drain to the parotid region, 11% to level 1, 72% to level 2, and so on. This is all available on the internet, and you can just do it interactively and predict where the lymphatic drainage is going to be. So, where does all this leave us? Although the probability of lymphatic drainage from a primary tumour on the head and neck, whether it be a melanoma, a squamous cell carcinoma, or a Merkel cell carcinoma, can be predicted with great precision using this sort of computerized tool, in the individual patient, you have to do the lymphatic mapping if you're to work out what is actually happening in that particular patient. And lymphoscintigraphy allows rational management decisions to be made, I think, and probably renders obsolete surgery and/or radiotherapy, which is based purely on algorithms. Thank you very much. It's been a great honor.
Thank you, Dr. Thompson, for sharing your experience with us. I know that this is a fitting tribute to the memory of Chris O'Brien, who was so dedicated to taking care of patients with head and neck melanoma, and you have made many contributions in the field. Thank you very much.